All right, good afternoon, everyone. I know we're having a couple folks continue to join. Just want to say thank you to you all for taking your time out today, for joining us on this busy day, this wonderfully sunny Thursday afternoon, to be a part of this webinar that's developed by the HPV Cancer Free Georgia work group, which is the HPV work group of the Georgia Cancer Consortium, Cancer Control Consortium, which we fondly referred to as GC3. I know it can be a mouthful. My name is Astrid Wilkie McKellar, and I am the manager of the Northside Hospital Cancer Institute Community Outreach and Engagement Program. I also serve as one of the co-leads of the subcommittee of our HPV work group, the Community Engagement Promotion and Practice Subcommittee, in conjunction with Dr. Teresa McLean, who is the executive director of the Georgia Colon Cancer Prevention Project out in Athens, Georgia. So we are thrilled to have you all here today. We look forward to the amazing information, the speakers, the experiences that we plan to bring to you in this part of this webinar on this HPV Awareness Day. This event is part of a number of activities that are happening across the state. Even this morning, there was a grand rounds, pediatric grand rounds, and it was wonderful to hear some of the education that's shared with our providers around HPV education and vaccines, and some of the conversations that we all need to continually have with our families, our friends, our providers, our residents throughout the state. So again, welcome to you all. Thank you again for taking the time to join us today. We have a jam-packed day, so we are going to jump right on into it. I'm very, very excited about the wonderful expertise and personal experience that we will share with you all today. Especially thankful to our survivor, who you will hear his incredible story in just a little bit. I just want to remind you all that this day is focused on, continuing to provide education around the cancer diagnosis, sharing the education, bringing attention and awareness to HPV education, HPV prevention, the treatment, just the ways to reduce the burden of HPV-associated disease and cancers on our society. So this is a ubiquitous infection. We know that everybody is open to it. And so it's incredibly important that we share this information. So just a reminder, the event is being recorded and will be available through the HPV Cancer Free Georgia website. So if you are unable to get your colleagues or friends to participate in today, please do direct them to check out the website later on. Also, the event has been approved by Piedmont Healthcare and the Georgia Dental Association to offer continuing education credits for physicians, nurses, and dental professionals. So the link for the evaluations will be shared in the chat box at the end of the event, as well as in a follow-up email that'll come directly afterward, or maybe tomorrow. And in order for you to receive credit, as you're all very well aware, you do need to complete the evaluation. And our financial disclosure, our planners, our faculty have nothing to disclose. And let us just jump right on into it. So let's get those juices flowing. Let's start with a polling question. What is the most common cancer caused by HPV in the United States? We'll give you all just a few minutes to respond to the poll. I think I'm hoping that we can get to a good, 75% or so of our respondents. We want to be sure that you are in this with us today. We see a lot of respondents coming in. Cervical seems to be top so far. We've got a couple of oropharyngeal. A lot of cervicals coming in. Keep those responses coming in, folks. We've got oral, throat, head and neck. Yep, keep them coming. We will share the answers so you'll know. So let's see, what are we at? Our percentage is, we're heading up there. Can we get to that 75% of respondents so far? We've got a lot of, we don't have anybody coming in for anal or penile yet. That's interesting. Okay. More than half of our respondents have responded. Our participants have responded. And it looks like we are plateauing. All right, we'll give you 10 seconds as you're thinking about it. The last bit of responses coming through. And we will be able to hit my 75% participation rate. Maybe? Well, I'll take it. We're just about at our 70%. We'll go with that. It's higher than our vaccination rate right now, unfortunately. We did hit 70. We'll go with it. Okay, so we'll go ahead and close the poll. And so far, 60% of our respondents have said cervical. 40% have actually said oropharyngeal. And the correct answer to that is oropharyngeal, head and neck cancers. And so we've seen that transition happen in the last few years, which is why it's so vitally important that we share this information not only with our young ladies or parents of our women, but our boys as well. So we will touch on this quite a bit more as we continue through the presentations today. So before we jump in, we would like to say thank you to our partners. We are grateful to the Georgia Dental Association and their partnership. We have Dr. David Resnick, who is a graduate of Emory College and Emory University School of Dentistry. He's Director of Oral Health at Grady's Infectious Disease Program. He founded the program 26 years ago. And he also serves as the chief of the dental medicine service for Grady Health System. He's president and founder of HIV Dental Alliance. It's a nonprofit concerned with healthcare providers committing to assuring access to the high quality and oral healthcare for people living with HIV disease. And he also serves as the vice chair of the AIDS Institute. He's a recent appointee to the Georgia Board of Dentistry and involved with the Georgia Dental Association. And he's also on the board of the Georgia Oral Health Coalition. So we will have a few words from Dr. Resnick.
About HPV in the oral cavity. It might come as a surprise to you, but oropharyngeal squamous cell carcinoma is now the most common HPV-related cancer, even more so than cervical cancer in women. So it's really important that we do a good soft tissue exam, look at the tonsillar pillars in the base of the tongue. But cases that I have found with squamous cell can even appear on gingival tissue. So when you see something abnormal, a biopsy is probably a good idea. I think it's important as members of the healthcare team, as primary care providers, that we talk to our patients about the importance of getting HPV vaccination. If we could get people vaccinated, we truly could eliminate oropharyngeal squamous cell carcinoma, or the most common head and neck cancer. As a matter of fact, men are more at risk. They are 6 times more likely to present with high-risk oral HPV compared to women, and much more likely to present with a cancer diagnosis. So please take the time, do your soft tissue exam, talk to our patients about HPV vaccination, and let's do what we can to eliminate head and neck cancer. Thank you so much.
Thank you so very much for those words, Dr. Resnick. We are all in this together for certain. So next, we'd like to hear from Dr. Nabil Saba. Dr. Saba is he is an internationally recognized expert in this head and neck cancer space. And we are absolutely thrilled to have him present with us today. He leads several clinical trials and chairs national as well as investigator-initiated multi-institutional studies focusing on novel approaches for treating these diseases. Dr. Saba is professor and vice chair for quality and safety, Department of Hematology and Medical Oncology at Emory University School of Medicine. He's also the Lynn and Howard Halpern Chair in Head and Neck Cancer Research at Winship Cancer Institute at Emory. He's an adjunct professor, Department of Otolaryngology at Emory University School of Medicine, and co-director of Head and Neck Cancer's multidisciplinary program at Winship. I don't know where he finds the time, but he is also additionally been appointed as the member of the ASCO Clinical Guidelines Committee, as well as the ASCO Head and Neck Guideline Advisory Committee. So we are grateful for his presence, for his expertise. Dr. Sala, we look forward to your presentation.
Thank you so much. And it's a great pleasure to be talking to you today about a disease that is a major, major healthcare problem. And can I have the next slide? Next slide, please. So as mentioned, in head and neck cancer, we have multiple areas where the disease is, and I don't know if you can see my pointer, but basically the oropharynx, which is the area right behind the oral cavity around here, where we have the tonsil or the base of tongue, is where HPV-related cancer predominantly happen. Next slide. And essentially, this is basically telling you the same, which is that we basically see it in the tonsil, we see it in the oral tongue. There are other areas that could have HPV-related cancers. However, we still don't know the exact significance of these other areas when HPV is affecting them. The vast majority, however, of patients who come to us with oropharynx-related HPV-related disease. Next slide. This is the breakdown of the frequency or the total number of patients per year of HPV-related cancer. The data is from a few years back, I understand, but you can see clearly that, and you have the 5-year overall survival here on your far right side here. You can see that oropharynx cancer, which is the cancer we were just discussing, tops all the different HPV-related cancers as far as a frequency of occurrence in the United States. And look at the overall survival. This is not a disease that results in great overall survival like cervix cancer. So you have 50% of patients who are alive at 5 years. Clearly a disease where we need to focus on novel treatment modalities and improve the care for patients. Next slide. And, this is to stress on the fact, 60% of you answered that cervix cancer is the predominant HPV-related disease. Yes, this was the predominant HPV-related disease prior to 2008, 2009, where basically the two curves crossed. We can talk about why cervix cancer is decreasing. The two main determinants of this is the fact that we do have a precursor lesion. You can look and identify a precancerous lesions for cervix cancer. This is not the case in oropharynx cancer. And we have still yet to determine a precursor lesion, in addition to the fact that, vaccination has taken off more commonly in cervix in women compared to men, and oropharynx cancer is a predominantly male disease, as we will show you. Next slide. So it's interesting that there's basically a lot of rationale to essentially use an HPV, the HPV vaccine to prevent oropharynx cancer, because those two HPV subtypes, HPV 16 and 18, are the same that cause cervix cancer as well as oropharynx cancer, and so the vaccine should very well prevent oropharynx cancer. Next slide. This is the difference between men and women based on the decade. You can see that this data goes back to the 1800s even, and you have different age groups here that are listed. You can see that oropharynx cancer has been a predominantly male disease. I have very rarely seen such a drastic difference between the two genders. Whereas in women, it is present, but certainly not to the same extent as in men. Next slide. And by the way, it affects different age groups. Another way to look at this is essentially looking, the lighter the color here, the higher the ratio of men to women. And essentially you have basically the same data here looking at the decade of where the data is looked at versus the age group. So you can see that, you have people between the ages of 40 to 44, so on and so forth, until the ages of 80. And you can see that there is a higher and higher proportion of men. And when time passes, there's an aging, there's increased proportion of older men who have this disease. Next slide. So it's interesting that the oropharynx cancer among women is increasing in countries where oral cavity and lung cancer is increasing, consistent with the tobacco risk factor, whereas oropharynx cancer in men is rising in regions of the world where oral cavity and squamous cell carcinoma of the lung are declining, which is consistent with HPV as a risk factor for this disease in men. Next slide. So this is a projection to 10 years from now. This is basically up to 2030, not really 10 years, a little less than 10 years, but you can see that the predominant group of people who continue to be affected are going to be Caucasian men, even though you can see that the different age groups here, and we can see that the projections up to 2030 for people who at that moment in time will be in their 40s is actually plateauing. This is because people are expected to have been vaccinated early on, whereas we're not vaccinating older individuals currently who are in their 40s, and therefore the curve continues to increase dramatically. And we are going to be faced with an explosion of cases in the next few years of men having oropharyngeal cancer. This is another way to look at the slide. So you have here men and women, and you have here Caucasian men in blue. You have African Americans in red. And you can see that in women it is increasing, but certainly we are expecting an explosion of cases over the next 10 years. And you know, which makes this symposia like this one very, very important to raise awareness for this disease. So remember cervix cancer. Cervix cancer is on the decline. Remember the curves for oropharynx cancer. It is on the rise, and we still have not reached a plateau as far as where this is going to end. Next slide. This is another way to look at it. Basically, you have oropharynx cancer, you have cervix cancer, and you have the number of cases here, depending on, the racial background. And you can see that, HPV affects other types of areas, certainly vaginal cancer, vulval cancer, but oropharynx cancer takes the lion's share currently of this disease. Next slide. This is a disease that affects people's lives in a major way, and we will hear from Wayne later on as far as what his experience was. But certainly, we have the HPV negative patients with oropharynx cancer who do really bad, and you can look at the survival here. Even though HPV positive do better in general, this is a mixed bag of situations here, and we certainly see the patients with HPV positive disease who do very badly. And this is just to impress on you that this disease is not curable in every patient. Next slide. So this is also stressing on this. If you look at the patients with good risk category, they have an excellent survival. However, when you start looking at patients with large volume of disease, lymph node positivity, the outcome of these patients is clearly worse, as you can see here. Next slide. So we talked about the fact that there is no screening method for HPV-related oropharynx cancer, which is basically hindering our capacity to basically detect early disease. We don't have a precursor lesion. We don't have a lesion that is precancerous that we can identify. So many times patients present with already locally advanced disease. The majority of patients actually we see already have disease that has spread to lymph nodes. And the majority of these patients also need drastic treatment with radiation and cisplatin chemotherapy. And for those of you who know oncology, I don't need to tell you what radiation and cisplatin chemotherapy, what the cost is to patients, but I will mention some of this in the next few slides. Next slide. So this is a patient who received radiation and chemo, and he has what we call osteoradionecrosis, which is necrosis or dead bone. Dr. Boyce sees many of these patients in our clinic. So this is just to show you that the burden on patients when we do these treatments is really, really high. And these diseases are very difficult to treat. They require very high expertise and a multidisciplinary team, which we have at our cancer center, that may not be available to everyone out in the community. Next slide. When we look at the differences between HPV positive and HPV negative oropharynx cancer, we can see that we can actually control the disease locally for HPV positive. But when we look at the frequency of distant metastases, in other words, the cancer spreading outside the neck, those two diseases appear to be similar, which indicates that we are seeing more and more patients with this disease present to us with incurable metastatic disease. Next slide. This is also looking at the same. You have 40% of patients here among patients who have recurrent disease presenting with metastatic disease, which is a substantial number of patients who fail treatment. Luckily, we can still cure a large number of patients. However, this is a fact that we are seeing more and more patients with metastatic disease. Next slide. This is, many of you have heard about immunotherapy and how great it does in head and neck cancer. We are very excited about it. However, immunotherapy has limitations. This is a trial using immunotherapy versus chemotherapy for patients with metastatic disease. Next slide. At 2 years from the treatment, about even patients who get immunotherapy, about 1/3 of them are alive. This, of course, includes HPV positive and negative disease, but this is to impress upon you that even though this is encouraging, we still lose many, many patients to head and neck cancer who have metastatic disease. Next slide. And this is a breakdown between the HPV negative. P16 negative is another surrogate for HPV versus P16 positive. And you can see that even though the HPV positive do slightly better, we still have a high burden in terms of death on patients who have HPV positive disease. Next slide. This is what we see in clinic. We have a patient coming into us with a big neck node here. This is a 47-year-old male, never smoker. So remember that this disease, it does not have to occur in smokers. The patient is otherwise in good shape, has never had any problems in the past. When we see this type of presentation, we cannot remove this with surgery. This patient needs to receive chemotherapy and radiation. Next slide. So this patient ended up having also a lung lesion, which is not very uncommon when we see this in clinic. And this patient ended up with metastatic disease, which actually precludes the treatment for local disease. And we really go with systemic therapy. In other words, either chemoimmunotherapy or immunotherapy. And I just showed you the curves for these patients. So these patients, a number of them actually have to face very, very dreadful situations when we see them in the clinic. Next slide. This is a vaccine trial, but this is not the HPV vaccine for prevention. This is vaccine for tumor. This is a tumor vaccine. Big difference between, vaccinating to prevent disease and vaccinating patients with the disease. But I'm showing you this to indicate that the immune system is still active. Even when you have metastatic disease, you can still target this disease with immune vaccines or with immunotherapy, indicating to you that the immune system recognizes this virus, recognizes this disease, and we need really to work on the best way to enhance the immune activation, which is really vaccinating people before they get the disease. When your immune system is ready to fight this cancer and it's trained already to fight it, then you have a high chance of preventing this cancer from happening. Next slide. Next slide. I'm going to skip this one. This is just to give you the complexity of what we're trying to do. A lot of people think that HPV positive disease it can be treated with less intensive therapy. This is an example of a trial where we're trying to lower the intensity of treatment, but what ends up happening is we're still giving big doses of radiation and big doses of chemotherapy, cisplatin chemotherapy, or immunotherapy. And it will take years before this trial allows us to check even whether we can reduce the intensity of therapy. And this, by the way, is for patients who have good risk features. In other words, HPV-related cancer patients who have relatively early stage disease, not the locally advanced disease. Next slide. This is, on the other hand, a trial for locally advanced disease. We give full dose of radiation, full dose of chemo, and we follow that with immunotherapy in half of the patients. That trial is also, we're seeing many, many patients with this disease, and this trial is really accruing multiple patients. As I showed you, this is almost, I can't use the word epidemic, but it is becoming close to an epidemic of HPV-related oropharynx cancer. Next slide. So So you ask yourself, who in the population could have this HPV related cancer? Those are normal individuals. They don't have cancer. They're men and women. So if you're walking on the street and you're in these age groups, let's say men between the ages of 40 to 49, about 45% of you have HPV viruses in the mouth, okay? Similarly to women, when you're walking on the street, regardless of this age group, even older individuals have HPV. So this is very, very common occurrence in the oral cavity and oropharynx. Next slide. And when you look here at the types of HPV that cause cancer, about 20% of men, for example, between the age of 40 and 49 have this type of virus. Of course, not all these people will end up with cancer, but certainly this is the group that ends up having more and more risk for developing these tumors. Next slide. So this is to put it again in perspective. This is between men and women. Of course, men take the lion's share here of oropharynx cancer, and this is the HPV distribution between oropharynx, cervical, anal cancer, and vulvar cancer. And you can see again, but presented in a different graph, that oropharynx cancer is the predominant disease here. Next slide. Similarly, here, HPV attributed cancer in men and women in the United States, and the previous slide, I think, was essentially for men. Next slide. So what is the indication or the recommendation for HPV vaccination? For men and women between the ages of 9 to 45, the recommendation is that a vaccine is recommended, especially for younger men and women. But that still can be given per CDC recommendations up to the age of 45, as I will detail in the next few slides. Next slide. So if you're between the ages of 11 to 12 and you're a man or woman, boy or girl in this case, you should be getting this vaccine. It can be given starting the age of 9 years. A catch-up vaccination is recommended for men and women through the age of 26 who are not adequately vaccinated. So you could end up with catch-up vaccine. And even if you have not been vaccinated up till the age of 26, clinical decision-making, in other words, discussion with your physician, discussion with others, could allow you also to have what we call a catch-up vaccination here up to the age of 45. The reason we don't go beyond that is because by that time, many you are very likely to have been exposed already to the HPV virus. Next slide. But how are we doing with this? How are we doing with this vaccination? Dismally, okay? Among men and women between the ages of 19 and 26, only 21% of men currently are receiving the vaccine. Very, very low numbers. Among 27 to 45-year-old, 3% of men are receiving this vaccine. I just showed you the curves of where we're heading in terms of the curve of incidence and the dramatic effect that this disease has on patients who have it, and the urge to actually vaccinate people. But we are doing really, really badly as far as the number of people getting this vaccine, which is why a symposium like this one, I think, is very important and needs to be probably done very often and more often to raise awareness. Next slide. This is a last slide I have, and it's basically a slide that I put in every head and neck cancer talk I do, whether it's related to vaccination or not. Most of my talks are related to management of head and neck cancer rather than vaccination, but I'm a medical oncologist and I see the worst of the worst in terms of managing patients with HPV related cancer. And this is basically our cancer center essentially is among many cancer centers that are advocating and pushing for HPV vaccination. I'm going to say, because of this impact that HPV has, that HPV vaccination, I'm going to quote this, is probably the most effective immuno-oncology tool against HPV-related oropharynx cancer at our disposition. So I think we need to really try to urge vaccination. I know in other countries, such as Britain, this is mandated, that you have to get vaccinated. And what I would add also is a quote from one of the manuscripts that looked at this. And I love this quote because it really identifies the core issue here. Which is that identification of a single necessary cause of any cancer provides a rare and perhaps extraordinary opportunity for cancer prevention. And I hope that this symposium will be, one of multiple that will actually hopefully raise awareness with your help to try to prevent this disease. And I think you can go to the next slide, but I think that's the last slide I have. And thank you very much.
Dr. Salva, thank you so very much for that very eye-opening, very informational presentation. I think it certainly just underscores the importance of us having these conversations with all of anyone that are within our spheres of influence, regardless of gender. Whereas we were previously so much associating cervical cancer with HPV, it's clear that that is so no longer the case. So thank you very much. We appreciate your expertise.
Thank you.
Next, we would like to have Wayne Lewis come up. He is a tonsil cancer survivor, to come and share his story with us. I think it's very important for us to also hear the personal side of how these cancers can impact the individual and the families. Wayne, I will turn it on over to you.
Great, thank you. So Dr. Boyce reached out to me, probably 4 or 5 weeks ago to share my story. So I'm happy to do that. Hopefully I can share a little insight and perspective on my journey through throat cancer. So you can go to the next slide. So before I dive in too deep about my journey, I'll tell you a little bit about me really quickly. Again, my name is Wayne Lewis. I'm a Atlanta native, born and raised in Smyrna, Georgia, a proud graduate of the Georgia Institute of Technology. I'm currently a director of engineering for one of the largest contract logistics companies in the world. And I'm very proud of my family. I've got 5 adult kids, ranging in age from my youngest is 25 and my oldest is 31. And I've got 1 grandson that you see here in the pictures. I'll tell a little bit more about him in a minute because it's part of my journey and story. For fun and for our interest, my wife and I love to travel. We don't do it as much as we'd like to, but we've been to some pretty cool places and would like to do more traveling with just me and her, and also with our family. We've got 3 dogs. We love hanging out with our dogs. I'm still a rock and roller at heart, so that you can see one of the pictures in this slide basically shows me and one of my sons at a concert. And one other thing that probably not reflected here on this slide is that my wife and I guess probably unfortunately have raised a family of foodies. So we love to eat and love to enjoy good food. And obviously that has a little impact on my journey as well through cancer. You can go to the next slide. So a little bit about my story. I think probably the most fascinating or complicated aspect of my diagnosis was the timing of when I found out I had cancer. So I'm sure you all remember that in March of 2020, the pandemic hits the US, and basically we're in a state of emergency and we've got a crisis. Coincidentally, that's exactly the time frame that I discovered that I had throat cancer. So the timing couldn't have been any worse. And then just in terms of how that impacted treatment and diagnosis, I remember, I think we were driving to church one morning and my youngest daughter said, "Dad, I think you've got a lump on your neck." And I felt it, probably didn't think a whole lot about it. But I remember in the days following, I'm shaving thinking, yeah, there is some sort of lump in my neck. So I reached out to my primary care doctor. He was able at that point in time for me to come into the office. And so I saw him. He said, basically, this is not just swollen lymph nodes. We need to get some tests run. So basically started on a journey of getting some test runs, a CT scan, I think a couple of those. Got referred to the head and neck office where I went in there. And because of this whole pandemic situation and the fact that this point in time, all the rules were changing in terms of what offices could and couldn't do in treatment. They were not able to scope me at that time. I think they tried to do I don't even know what you call it, some sort of biopsy right there in the office, but it was inconclusive. So they ordered a biopsy for me to go into the hospital and have a section of the back of my throat removed, and then basically got the bad news that it was indeed throat cancer. And that picture in the bottom left of the trees and me and my wife, I remember just laying on our trampoline in the backyard and just really just processing this and trying to take it all in. It was pretty scary. I think I was still probably in denial. My wife had basically received the news and was ready for the journey. It took me a while to process it, but we basically then moved into the next stage of the whole diagnosis, which was meeting with the cancer team and talking about the treatment options for me. Again, because of the timing of this, the original recommendation was for me to receive chemo and radiation treatment. Surgery was not an option at the time that I went in for my first consultation. So that was kind of heartbreaking, to be honest with you. I really wanted this cancer cut out of my body. But when we first met with the team, that was not an option. I was professionally persistent and basically reached out to Dr. Boyce and his team several times. And then finally, the state of Georgia rules of engagement changed and the hospitals opened up, and I was able to get the surgery scheduled. You go to the next slide. So on May 14th of 2020, I was able to get in and have surgery done. So I believe the type of surgery done, it was a robotic procedure. I think it's called TORS. Part of my left tonsil and back parts of the back of my throat were removed. Stayed in the hospital for several days. Was pretty miserable, but had a pretty good recovery. Again, one of the challenges because of the timing was I kind of had to do this journey alone, and I'd never had any sort of major surgery, never been in the hospital before. And again, this was all in the middle of the pandemic, and visitors weren't allowed, family wasn't allowed. So I've got a picture there in the middle showing my family coming outside of my window at the hospital. They called me on the phone, we communicated. You can see me, the shot from me looking through the window, but trying to encourage me and tell me to hang in there. So that was the situation I was in. And then I got released and went home. And then unfortunately, within 24 hours, I had a fever spike and had to go back into the hospital. And again, because of the pandemic situation, I had to go in through the ER, and it was pretty difficult to get through that whole ER situation and get readmitted, and then stayed back in the hospital for 3 or 4 days before I got stable. My fever was under control, and then got released around May 22nd of 2020 after that second time through the hospital. So pretty tough journey. I did put a picture here of something my daughter put on Instagram, that when I was preparing for this and just kind of looking through pictures and kind of rethinking my story, that was really emotional for me to just look back and just knowing that the impact of my kids thinking about their dad and potentially losing their dad, and or just what their dad was going to go through, just really really moved me again as I thought back through this journey. You can go back to you can go to the next slide. So what did recovery and treatment look like for me? So you can see I've got a tube in my nose. So I had a feeding tube for about 3 weeks. And so I recovered at home. Everybody in my family got involved in feeding dad in the feeding tube. So my medicines were coming through the feeding tube. My nutrition was coming through the feeding tube. And I think it was fundamentally Ensure. I'll tell you something about that here in a minute. And then finally got my NG tube out about 3 weeks after that. That was a great, thrilling time to get that feeding tube out. And I remember my wife and I driving to Stony River Steakhouse. I wasn't in a position to eat a steak, but I remember going there and getting some lobster bisque or crab bisque. I can't remember what it was, and some deviled eggs. And it was so good to not be eating soup and pudding and some soft pastas. And really the thing that my kids give me a hard time about was that strawberry Ensure that I drank all the time. They said that smell reminds them of cancer, and it reminds them of COVID. It's just a very distinct smell. So once the feeding tube was out, a few weeks after that, basically the next step in my treatment was radiation. So started on a 6-week, 5-day-a-week journey to do radiation. If you're not familiar with kind of the process, I wasn't. Basically, a special mask was made for me, and I would basically lie on a table. They strapped me in with my mask, and the treatment was very brief. And basically did treatment for 6 weeks, and then I was done and got to the end of it. You go to the next slide, and I'll wrap it up here in just a second. So again, radiation ended on August 6th. They have a little celebration ceremony at the place where I went. I got to sing a song, ring the bell when it was my last treatment day. Finished radiation, and then subsequently I had lymphedema therapy that I did in the latter part of 2020. And then in July of 2021, I had the scar where they had removed, I think, 39 lymph nodes. We had that revised and cleaned up a couple of things that were going on there. And then in the middle of this, I've got a picture of my grandson. And basically, I shared that not only because I'm proud, because that was what encouraged me through this whole journey. There was always hope. My daughter was pregnant with our first grandson. He was due in August of 2020, and he came on August 31st. So I always had that hope that I was going to see him. And so that kind of just carried me through this whole journey. So I had a lot of friends and family come alongside me. They encouraged me, supported me. And, I'm thankful for where I'm at. I think my prognosis looks great. I've been doing regular scans and treatments. And I think my 2-year milestone is coming up in August, and everything looks good. So I'm very thankful. And hopefully my story provides some not only awareness, but maybe some hope and encouragement for anybody that's battling cancer or knows somebody that is. Thank you.
And thank you, Wayne, for allowing us to share in your story today, to celebrate you on this HPV Awareness Day. We are grateful. I mean, each story is unique, without a doubt. But your story of inspiration and influence, resilience is just, it's amazing. And we are grateful that you are here to be able to share it with us. We say congratulations on all that you have accomplished, and certainly on that beautiful little baby grandson of yours. We will continue to move us along. We did have another polling question, but I think we will, in the essence of time, continue on with our presentation. So next we've got Dr. Carrie Kelly. Dr. Kelly is a pediatrician and assistant professor at the AU-UGA Medical Partnership in Athens, Georgia. Carrie grew up in Midway, Georgia, prior to moving to Athens in 1996 to attend University of Georgia for her undergraduate studies. And after graduating from residency in 2008, she practiced in the Athens area for 12 years prior to transitioning to her current full-time teaching position. So Dr. Kelly is very passionate about vaccinations, which you will certainly hear more about today. Dr. Kelly, the floor is yours.
Okay, great. Thank you so much. So I just am going to talk about some of my personal experiences as a pediatrician with the HPV vaccination. Over my career, I've been able to see like the true power of vaccines. The rotavirus vaccine came out when I was in residency, the new one. And then the HPV vaccine also came out when I was in residency, and I'll talk about that a little bit. So we can move on to the next slide. These are some of our objectives that we're going to cover today, and we can go ahead and move on to the next one. And Dr. Saba covered this really beautifully, obviously, so I won't go into too much detail here, but obviously we can see kind of HPV affects a lot of people. So it is an incredibly important topic and an important infection to prevent. And we have a way to do it. So we'll talk about how to kind of get people on board with the vaccination that may be a little bit hesitant. At times, how common this cancer is hard to convey to parents. All of my patients were the children that were getting this vaccine. So I was mostly talking to the parents about whether or not they wanted to get their child the vaccine. So, it's not, unfortunately, these cancers aren't kind of at the forefront of discussion many times until now. Luckily, we have things like this that hopefully we're getting the word out there more, but I'll talk about a little bit more later how I had to explain to people how this HPV could lead to cancer. I didn't have a lot of patients or any patients with cancer from HPV, but I did have little babies, newborns that would have breathing trouble from lesions due to HPV. So they'd even have to be intubated because of that. I think sometimes this is an if you can't see it, you can ignore it situation, as many of us have seen with other infectious diseases. But this is hopefully an opportunity to put this more out there for people to understand how important it is. So the bottom line here is this is a cancer and other disease-causing virus, and its effects can be prevented with the HPV vaccine. And specifically for cervical cancer, many people with a cervix may not have access to surveillance testing. So prevention truly is key. We can move on to the next slide. So the American Academy of Pediatrics, which is the AAP there, and the CDC recommend this vaccine, the HPV vaccine, between the ages of 9 and 12. When I started residency, was in 2005, and then this came out in 2006, and we did offer the vaccine at age 9. At the time, it's hard for me to remember the uptake at that time, but in the years following, when I started practicing in my own clinic here in the Athens area, it was more typical to give this vaccine at the 11-year-old well check. And you may or may not know, but at the 11-year-old well check, there's 2 other vaccines that are given that are typically required by schools, public schools. And that's the Tdap vaccine and one of the meningococcal vaccines. And so it was an opportunity to say, and we're going to do this one as well. So this many times was our chance to get that first HPV vaccine in. It is unfortunately incredibly common for patients to miss their 9 and 10-year-old well checks because there's not really any other mandatory or forms they need at those visits to attend school. And so sometimes those get skipped. However, if you do have a patient show up for their 9-year-old well check, it is a great idea to go ahead and offer the HPV vaccine right then. You have a much better chance of completing the series if they've already received their first HPV vaccine before the 11-year-old well check, so that you can give them the second and usually last one right then at the 11-year-old well check. Because I'll talk about this more in a minute, but the younger you are, the better the antibody response is to the vaccine, which again is another huge reason to offer it as young as possible, starting at age 9. But it also, several years ago, they went from 3 in the series to 2 if you're younger when you get it. And so that was a big point I could talk to parents about. This vaccine is working so well, they really only need 2 vaccines now. So if you can get the first one at 9 and the second one, hopefully 6 months later, but if you don't and you get it in 11, you've completed the series, which is incredible to complete that by age 11. Some of the barriers are parents do not like to give their children shots. And this one does hurt. It hurts a little bit more than some of the other ones. So some parents are like, just want to get it all over at once at 11. However, there are a lot of parents who love to split up vaccines for the same reason, for the pain. They don't want them to have 3 shots. They just want them to have the 1. And so I think a lot of parents would really appreciate the opportunity to be offered the vaccine at a different visit than the 11-year-old visit. So you can start at 9. If they come in for their 10-year-old visit, start it then. But getting it in as early as possible is incredibly helpful in making sure they complete the series, by age 12. Many of our electronic medical records now have reminders that you can remind patients about well checks or remind patients about coming back for the second shot in the series if they're in the age range to get the 2-shot series. And so that's really important if you have that availability to use that to remind parents to come back in and bring their child back in for those. But it can also help remind people to come in for those 9 and 10-year-old well checks. The bottom line is the earlier we can start the series, it helps ensure completion of the series and the best antibody response to the vaccination, which likely is going to prevent more cancers. And finally, we can move on to the next slide. So how do we get people that are hesitant to take this vaccine for their child? So motivational interviewing has been shown to be very effective in talking to vaccine hesitant people and patients and parents. The good news is many parents are very readily accepting of this vaccine. This has greatly improved over the last decade in my experience. And if I suggested, or if I said they're due for this vaccine today, most of the time they said, okay, especially in the last few years. But of course, there are many people that are still hesitant, specifically about this vaccine. And this is not one that you have to attend school. So it wasn't one that they just had to get to go. So it was one we had to talk about a little bit more. The big thing is it is essential for pediatricians and other healthcare providers to strongly recommend the vaccine. There's room for improvement here for all of us, but the most important thing is your tone. Instead of saying something like, we can do these two, the Tdap and meningococcal vaccine today, and there's also an optional HPV vaccine. You can see how that tone doesn't really encourage the parent that you believe in this vaccine as well. But if you say, Judy is due for the HPV vaccination today, it's a statement, it's a recommendation, and it tells the parents that you have confidence in this vaccine. And you can also explain, of course, about how it can prevent cancer. Focus on the cancer prevention. That helps parents recognize the importance as well. You just say that it's part of the normal vaccination schedule. If they're 9 and they're not getting any other vaccines, you just say the one vaccine. Judy is due for the HPV vaccination today. We will do that after we complete her visit. Honestly, this is hard for new physicians, I think, coming out. Earlier in my career, I didn't have the confidence sometimes to, quote, defend things like this, or especially if parents were getting upset. But as I have continued practicing, I've gained much more confidence and can have these conversations with parents. And most of the time, it leads to the child getting the vaccination. So that's been good, building confidence and being knowledgeable about these vaccination and the diseases are important. It is very easy to get frustrated as a healthcare provider in these conversations sometimes. And sometimes you can feel yourself getting upset, because how helpful this vaccine can be. But it's important not to show that. It's not effective to get angry with a patient, obviously. So the motivation, that's where the motivational interviewing comes back in. So with motivational interviewing, you're acknowledging that they have concerns and you're validating their feelings. You ask them to clarify their concerns, and then you can focus on the disease, not so much the vaccination. So focus on the disease that the vaccine prevents. Offer personal stories, personal feelings about your own decision to vaccinate your children or yourself. And then you do need to put it back to the patient and parent for a decision. Obviously, we're not going to hold anybody down and put it in their arm, but when you speak to them clearly in language that they can understand, and again, putting some of the personal stories in there, it really does help people see it's not just something we're doing to make money or, for any other nefarious reason. We really, truly are doing this to benefit the child. So for HPV, we would focus on the cancer more than anything that it prevents. We don't want to hide anything from the patients if they start asking about, STI or anything like that, because if you do that, you've lost quite a bit of trust there. So some of the things I found helpful that I personally said to patients that helped them make the decision were things like this, because some of the barriers are that, the parents think it will make their child sexually active if they get this vaccine. They do not think their child is anywhere near being sexually active, even at age 11 or 12. They don't think that their child will have premarital sex. I've had teenagers tell me that they wouldn't have premarital sex. And then of course, they've heard about some side effect or something so these are kind of the barriers we've had. But the things I would tell the parents is, I've seen a 12-year-old have a baby. Many people are shocked when they hear that. I think it doesn't, you see your 11-year-old child and they look like a baby, to you because they're your baby. But it's just not impossible for this to happen. HPV is so common that I would tell the parents, even if your child only has sexual relations with one person, if they've had relations with someone else, then they're at risk for contracting the virus. This was helpful for a lot of parents who really focused on the that their child would not have any premarital sex, because it took the quote target off their child. It wasn't saying that their child was going to be promiscuous or anything like that. And so they could appreciate that. Unfortunately, not all sexual contact is consensual. This one did hit home for a lot of people. It made people realize, that their child could be at risk, unfortunately, in that type situation. This one sounds a little bit out there, but there was an episode of that show, Say Yes to the Dress. You may have remembered that. I think it was the Atlanta version, but the bride had cervical cancer. She was in her early 20s, I believe. She got her dress. It was really beautiful. It was a great show. And then at the very end, it was a memorial for her. And that really hit home for me. You're watching this very happy show. They're all happy. She's going to get married. And then she had passed away from the cervical cancer. So I sometimes mention that to families, and some of them had even seen the episode. So, I told them, of course, that I would 100% get this vaccine for my children. No hesitation, no question. And that was also very impactful. And when I talked about earlier, going from the 3-dose to the 2-dose for the younger children under 15, that made a huge difference, because it helped them see like, wow, this really is working, and especially in the younger children. So the bottom line is, stay calm, have real conversations. Most parents aren't, quote, medical. And I say that, could be MDs, nurses, anybody. And even the medical folks don't have as much knowledge about some of these viruses as they could, because knowledge about these viruses comes out, more and more every month, seems like. So speak to their hearts and speak in a language that's very clear and easy for them to understand. And you can go to the next slide. And just to let y'all know, I got my first HPV vaccine in January of this year. It was even before I knew I was doing this talk. And, my doctor said, hey, your insurance will cover it. Would you like to get this vaccine? And of course, I had been telling patients for years and years that if it ever came out that I could get it, I absolutely would. So of course, I said yes right away. It did hurt, I will say. But it was great, because now I can tell my patients, you know what, I did what I said. I got my HPV vaccine. I'll be getting my second one very soon, and then my third one a few months later. So I'm happy to tell my patients that I and my son have both received our HPV vaccines this year. And that's a picture of me with my vaccine, which I asked the nurse if anyone had ever asked to take a picture with their HPV vaccine before, and she said no. So I think I was the first, but I was very excited to get it. And I appreciate y'all, and it's been such an honor to speak to y'all, and thank you so much.
Thank you, Dr. Kelly. I think it's wonderful that you end with a photo of you and the vaccine. There's no better way to close that presentation. We certainly appreciate your expertise and your insight, and really your understanding that each conversation does need to be unique and have a personal approach in addressing some of these discussions with our families. And so I will continue to move us right along. I just want you all to also be aware that in addition to the education and some of the other awareness activities that's happening around the state as it relates to HPV and HPV-related cancers, there's also quite a bit that's happening at our state capitol. House Resolution 998 and 1019 are both those recognizing today, March 24th, as HPV Awareness Day. House Bill 998 is HPV Awareness Day, and 1019 is HPV Cancer Awareness Day. So the Georgia Cancer Control Consortium is incredibly proud that our 2022 work to increase awareness and to help prevent HPV-related cancers has been recognized by the Georgia House of Representatives through the adoption of these 2 House resolutions. So we take this opportunity just to say thank you. We are truly grateful. House Bill 1416, however, is still on the floor, and it has not yet been passed as of yesterday, but this particular bill would require the Department of Education to provide information to parents and guardians of those students in the 5th and 6th grades about just recommendations about adolescents vaccines, including HPV, not only the ones that are required to attend school. So these are just want to make sure that everyone is aware that there's quite a bit of legislative activity happening as well. I do want to say a special thanks, though, to our legislators before we mention our awards. And Representative Kim Schofield, Terry Anulowicz, and Shay Roberts have been amazing in moving some of these things forward. And Representative Anulowicz in particular has been a champion really since 2018. And just she's been an advocate for Georgia's, our cancer community. And so as a matter of fact, she is one of our champions. And I'll just say a little bit more about her in just a minute. But just quickly about our awards presentation, the top 2 rows are our healthcare providers. And just so that you are aware, it's no easy feat to be awarded the HPV Champion Award. These organizations, these clinics, these clinicians have actually been identified by our Georgia Department of Health, their immunization coordinators, as kind of those rising above, really achieving some incredible HPV vaccination rates. It's between 60 and 70% of the entire series of their youth who have received, and that's actually ages 13 to 15, who received the entire series. So 60 to 70% it's a significant accomplishment, and we just want to acknowledge that. We've got WellStar, quite a few of the WellStar family, Georgia Highlands Premier family, the Pavilion family, Southwell Medical, and Sumter Pediatrics. Kudos to you all. And that last row, those are our community members. And so we've got Sims Johnson, Jana Mastro Giovanni, Allison Agnew, and Terry Anulowicz, as I mentioned, our state representative, who again have been doing amazing work in this space. And these are folks who've either hosted one or more of HPV awareness activities and events, and then have more than at least 50 people participate. And in this pandemic climate, that again is no easy feat. So we want to say congratulations to you all. We are incredibly indebted to you and the work that you continue to do to raise awareness, to continue to engage with our communities as it leads to increased HPV vaccination rates. So thank you, and congratulations to everybody. Now, I do want to just mention our HPV Champion Spotlight is coming from our Allison Agnew and our folks up in the Northwest Georgia Cancer Coalition. So I will have our words of inspiration. Hopefully she's got a video that we will see in just a minute. That was just a brief kind of overview of some of the work of one of our just highly recognized champions. The Northwest Georgia Regional Cancer Coalition is doing just amazing work. And this is just an example of all that's happening, honestly, across the state, from in Southwest, for some of the advocacy and education that's doing there in the East, and certainly in our North and Northwest region. So again, it's thank you to you all. I know we are slightly over time. I just want to leave you with this call to action. Honestly, you know, as you're participating in this event, we have all already donned you all HPV champions. You can look at the different categories on the screen and decide where do you fit, and maybe it's more than one, but that we all not just acknowledge the fact that we all play a role in helping to prevent HPV-related cancers through our conversations, through our engagement, through our educational presentations and opportunities, and through our personal influences as well. So if you are a medical provider, dental provider, pharmacy, or individual or parent, there is a role for each and every one of us. And as we can all agree, certainly preventing cancer is better than treating it. We have this one, really the second is after our hepatitis B, but this is an opportunity for us to prevent cancer. And as we've heard from Wayne's story, this is not something that we would want any family to have to experience. So we leave you with this call to action. You identify, where do you fit? And wherever it is that you fit in this role, in these list of groups of people, that your role is going to be significant. So we, again, don you the hat of HPV champion. So the question is, what do you do with it? We look forward to hearing that and seeing that. Before we close out, again, we thank you all for your patience and allowing us just a little bit of grace at the end of and going over just a bit. But we do want to say thank you to our sponsors, GRAIL and the Hispanic Health Coalition of Georgia. There will be a link in the chat if you'd like to learn a little bit more about what GRAIL and the Hispanic Health Coalition are doing. They're working on a partnership to work on better outcomes, and certainly, on all cancer types, particularly HPV, and with a focus on Hispanic and Latino, Latinx population. So please feel free to follow their link in the chat. Again, we want to say thank you to you all for participating in today's second annual Georgia HPV Awareness Day. We hope it's been educational. We hope it's been inspirational. We hope that you take it and do something with the information that you've been provided today, just to make a change to defeat HPV and HPV-related cancers. I'd especially like to thank all of our presenters, our speakers, for making the time for today. Wayne is our survivor. Thank you again for sharing your incredibly inspirational story. And if you are interested, anyone in joining our work group, you can contact Andre Bassi. His information is on the bottom of the screen, his email. Please feel to reach out to him directly. And you can also connect with us through our social media platforms. And so we encourage everyone, please do remember to complete the survey. And also, if you've been submitting questions in the chat, just know that although we weren't able to answer them directly, they will all be collated and responded to in the follow-up email, or you can look at our HPV Cancer Free Georgia website. So again, connect with us in one way or the other. Please do complete the survey. Remember that in order for you to get CEs, you do need to complete that. And even if you don't want CEs, we'd love to hear your feedback. We'd like to know what you enjoyed, what you might not have, and what you'd like to see again next year. So you can also follow up with Jana Mastroveni if you've got any questions, particularly about the survey. And yes, there will be a recording. So thank you all. Thank you for participating. We look forward to all of the incredible work that you will do next year. Maybe hear from some of you next year. Take care and enjoy the rest of your Thursday afternoon and HPV Awareness Day. Take care. Bye-bye.